I will say our both young men actually that we dosed here at the Hemophilia Outreach Center were not very compliant with their prophylaxis. And they're very willing to admit that.
Our guest today is Andrea Buxton. She is a family nurse practitioner at the Hemophilia Outreach Center in Green Bay, Wisconsin. Andrea led the clinical team of the first dose of gene therapy for a hemophilia B patient. So let's listen in to Andrea's retelling of the shared decision-making process from the all-important nurse's point of view and the reason why her two patients dosed made good candidates for gene therapy. A special thank you to Melody Joy Payne for conducting the interview.
I think as providers, it's our job to make sure we're educating on all new treatments, right? Not just gene therapy. But I think some patients are going to say, it's not the time for them, and that's okay. They might want to wait a while, or maybe they're content with their quality of life in regards to their prophylaxis schedule, their, maybe lack of bleeds currently, and those patients aren't going to make that choice, I think, to travel down the path. I think you're always going to have patients that are a better fit, and it's going to really come down to what are the patient's goals and value. A lot of the patients pursuing maybe the gene therapy have that same, maybe fear of needles, or they just, they're younger, and we know that younger people generally are not the most compliant with medications. And I think, or have always thought that ironically, it's, males that suffer from a bleeding disorder the most, right? We've got definitely a larger population of severe to moderate hemophilia males than we do females, but males generally are a little less compliant. In younger age, we have studies that show that just their health in general, they kind of feel like maybe they're almost invincible to having a significant bleed. And then unfortunately, they don't do their prophylaxis and they have a bleed, and they're reminded that that's right, I have hemophilia. And now I have to treat, or I'm going to have further problems. So there's been discussions, I know, amongst other healthcare providers in regards to if they're not compliant now, are they going to be compliant with that follow-up? Maybe we don't want to take that risk, but I think those are actually the patients that you will see benefit the most from gene therapy.
Melody then asked, what makes a good candidate for gene therapy?
There is a lot that we do before to make sure that they are a candidate for gene therapy. We, make sure that we check their liver health with both blood tests and looking at an ultrasound, and making sure they don't have significant fibrosis on their liver. We check to see if they have antibodies to the gene therapy. For hemophilia B, even if they do have some antibodies, it does not exclude them from receiving the treatment. We do know that there were patients, about 30%, that did have antibodies, but only one patient had a very high titer, and that was a patient that didn't respond. So we, make sure that there's no no active infections to Hep C, HIV, things that could cause the gene therapy not to work. You want to make sure you've got a good, healthy liver, because that's where the gene therapy transgene is going to, there's a promoter or like a honing beacon on the gene therapy capsid itself that targets the liver. So we need healthy liver cells. Once that's all done and, everything looks good, the patient, we do proceed with the insurance process, which can be a very drawn out process.
We were all wondering about that part. Andrea goes on to explain.
Don't want to pay for the most expensive drug in the world. So that does take a little time, but once that's completed and the patient is set up for a day of infusion, we have several visits in regards to education and making sure they understand the process. They have to actually teach it back to us for us to determine if they're fully comprehending what's going to be happening. And then they come into our center for the day of infusion. It's about a 1-hour infusion for hemophilia B, and then they're monitored for 3 hours afterwards, just to make sure there's no delayed infusion reactions that could occur. And then they have to come back weekly for lab monitoring for 12 weeks. So it's the process itself leading up and then afterwards for that 3 months is drawn out. But once they get kind of past that 12 weeks, we only have them come back once a month for 3 months, and then they're coming for their labs every 3 months. And once they hit a year, it's every 6 months. So it does gradually get less and less visits in between, especially once they hit that year mark. But we want to make sure their liver, there are patients that will develop elevation of their liver enzymes. And really, it's an immune response to this foreign substance going into your liver. So we want to make sure we watch that closely, because that could impact their factor IX from not going up like we would want it to. And then they're put on a dose of steroids. Our 2 patients, and Mason included, did have to go on steroids for a little while afterwards. But he was okay with that, just knowing that this would help keep his liver healthy and decrease that inflammation that was happening and allow his factor IX to continue to go up. So that wasn't an issue for him at all. And now he just comes to us every couple months.
Melody then asked a great question. What differentiates gene therapy as a treatment opposed to a cure?
Yeah, so there are, different types of gene therapies that have been tried, and not only for hemophilia, but also some different diagnoses. So there is, yes, gene editing, or like the CRISPR technology. There's the gene cloning. And for some of those things, depending on how the gene therapy is done, yes, we can say that, it's a cure, because we are fixing your actual genetic mutation. And now you have this completely normal DNA. You don't have any mutation left in it. Whereas this, we're just transferring this functional strand of your factor IX to produce copies. So we can't say that we're curing your hemophilia, because we're not. You still have hemophilia. In fact, Mason and other patients that receive this, if they have children, a daughter someday, they will still pass that mutation down to their daughter. And so it could still continue in the family for generations to come. So we're not curing their actual mutation, but we are delivering a copy that can produce its own factor IX, making it, what we call maybe a functional cure, in regards to you have hemophilia, but you don't have to treat your hemophilia like you did in the past, because your factor IX now is working or has a level high enough that you don't need to do your prophylaxis or have bleeds.
Thank you to Andrea for her candor, and thank you to Melody for her fabulous interviewing skills. There has been so much said about gene therapy from a clinical perspective, but now, since FDA approval for both hemophilia A and B gene therapies, we get to hear more of the humanity of the decision-making process. And we hope you are enjoying this segment, and a continued thank you to CSLBehring for supporting. Let's turn it over to Andrea for the final word.
We find that with a lot of patients with hemophilia or other bleeding disorders, they might have dreams and things that they've always wanted to do, but they can't because they have this bleeding disorder. So I think this, once we kind of see further down the road, like how long is this therapy lasting, those are avenues that could potentially open up for those patients.